Hello everybody and welcome to this evening's Facebook Live event. My name's Sam Ciotkowski and I'm the Sales Manager for the JCM. So I'd just like to start by saying a big thank you to all of you for joining us this evening. We really do appreciate you joining us and giving us your precious time to be with us on this event. I'd also like to thank Medicareplus for their support. We wouldn't be able to put on these events without the support of our industry partners, so a big thank you to them as well. Now, I'm sure you're all used to this by now, but we are filming this remotely, so do bear with us if there are any technical issues. We'll be working behind the scenes to get those all sorted for you as quickly as possible, and someone from our team will be in the comment section making sure you all know exactly what's going on if there are any issues as well. So this evening's session is titled End of Life Skincare, Challenges, Prevention and Management, and our speaker tonight is Stefanie Mahan, who is a palliative care clinical lead and independent tissue viability specialist nurse. Welcome, Stefanie.
Hello, welcome.
Thanks very much for joining us. Really looking forward to this presentation. Looking forward to getting cracking with it. So just before we get started on tonight's session, I'm just going to go through a couple of bits of housekeeping with you all. Firstly, the certificates. We'll provide a CPD certificate at the end of the session. So that will be a link on the slides and also a pinned comment in the comment section. So keep an eye out for that, but we will post that towards the end of the video. We'll also be back at the end of the session for a live Q&A. So throughout the presentation, please do send in any questions or comments that you might have for Stefanie, and I'll be back at the end to ask those questions during the live Q&A. If we don't get through to your question, then we will try and answer those in the next couple of days as well. So send in as many as you like and we'll answer as many as possible. Finally, the slides will also be available. They'll be on our website in a couple of days' time. So if you need those, you can access them there. We'll put a link again in the comment section at the end of the video. So keep an eye out for that too. So that's all from me for now. I'll now pass you back over to Stefanie. I'll see you all at the live Q&A. Don't forget to send in your questions and I'll see you in a bit. Thank you very much, Stefanie.
Thank you, Sam. So welcome everybody. And as Sam kindly said, I'm here this evening to go through end-of-life skincare, the challenges, prevention and management. So caring for dying patients presents many challenges, and not least the maintenance of skin integrity. Occasionally, despite receiving all the necessary interventions, palliative patients may still develop skin damage. End of life is defined as a phase of life when a person is living with an illness that will often worsen and eventually cause death. This is not restricted to the short period just before death, but may begin some weeks or even months beforehand. Deterioration of skin in palliative patients shouldn't be seen as inevitable. We can still assess and manage all skin issues to ensure that patients receive the best outcome. So the normal functions of the skin. Protection is seen as the primary function of the skin. And whilst it does offer protection from both mechanical and trauma damage, it also protects from infections, chemical irritants, and UV radiation. But it also offers us so much more, including metabolism, so the synthesis of vitamin D. And some of the population are seeing ill effects from the lack of vitamin D, and also the production of melanin. It acts as an absorption, so it's use of emollients for rehydration, and the use of emollients we use to maintain that skin integrity. Medicinal patches, and obviously many palliative patients do use medicinal patches, such as fentanyl. You've also got your medicinal ointments and creams, as well as harmful substances. So obviously cancer patients receiving radiotherapy, that is going to cause some absorption within the skin. Also, it acts as a fluid balance, so it prevents that water loss and promotes the hydration of the skin. It forms a function of communication through facial expression, touch, physical appearance, and the secretions of pheromones. It acts as an excretion, so we excrete sweat, as well as salts, water, urea, toxin, and the pheromones. And remembering that the skin is the main excretory route after the kidneys. It acts as a temperature control, so vasodilation, your hot touch sensations, as well as your vasoconstriction, so your cold, as well as sweating. And many palliative patients do feel that extreme temperature change. It also acts as a form of sensation through the nerve endings. It can detect pain, pressure, and touch. And patients who are peripherally shutting down will not have that normal same sensation that you and I have. And also it affects how that skin can communicate. So as we all grow older, our skin does change, and obviously the epidermis begins to dry and it reduces that sweat gland activity. It also thins and slowing that repair function. Therefore, wounds won't heal with our palliative patients, but we can manage them effectively. It decreases the vitamin D production. It reduces the number of cells that it produces. And again, our patients are higher risk of mechanical damage when they've got that thinner layer of the epidermis. We tend to overheat because it's got that reduced sweat gland, as well as the change in distribution of the fat and the hair follicles. It reduces the melanocytes, so the skin becomes paler, and it's reduced tolerance to the sun exposure. As we all age, that dermis layer thins and we get that sagging and wrinkling to the skin due to that collagen loss. We have a reduced blood supply. So again, it slowers that healing process and reduces that ability for us to lose heat. And again, we produce less of hair follicles, therefore we have thinner and sparser hair. Changes to the skin at end of life. It is anticipated that during the end stages of life, any of the number of vital body systems will become compromised to a variant degree, such as the renal, hepatic, cardiac, pulmonary, or nervous system. And as the body enters this stage, the vital organs will begin to fail. And the skin is yet another organ whose function may begin to deteriorate at end of life. The skin is the largest organ of the body, so we can visually see those changes occurring. And by intervening and putting them protection and prevention measures in place, we can protect the skin. So as the patient deteriorates, we can go through into acute skin failure. And this skin failure is often overlooked and not included in the patient or the family education. And it can become distressing if this develops. As I've said, the skin is the largest organ of the body, and it can and does fail, along with all other organs at end of life. But it's remembering that wounds such as this in this photography are not inevitable in patients who are dying. And by early intervention, we can manage the integrity of the patient's skin and prevent acute skin failure where possible. So the skin and subcutaneous tissue begins to die and becomes necrotic. And that's due to the hyperperfusion that occurs alongside the severe dysfunction and failure of the other organs and systems. This damage may occur despite the appropriate interventions of prevention, and that does not exceed the standards of care that we're delivering. But whilst damage may occur, it is our duty of care to ensure that despite the palliative stages the patient's is going through, that their needs are met, and we can offer them the management of their skin to prevent acute skin failure from happening. Managing skin integrity at the end of life can be extremely challenging and does pose complications, such as pressure ulcers. During the palliative stages, the skin does begin to fail, and patients are more predisposed to developing pressure ulcers, particularly when the patients are unable to move themselves. They lose their motivation and they become bedbound. Other end-of-life skin complications are moisture-associated skin damage, and this is one of the biggest factors for palliative patients, but can be the easiest to remedy if there is timely intervention in protecting the patient's skin integrity by using the appropriate barrier products. You've also got moisture-associated related skin injury, so shortened to MARSI. Obviously, as we've discussed, the changes to the patient's skin as they are nearing end of life or as they are aging, that skin begins to thin and the epidermis needs to be protected and becomes quite challenging. And when we are removing their medical dressings and devices such as stoma pouches, we are potentially stripping that patient's skin. So by applying preventative measures, we are preventing that medical adhesive stripping prior to the removal. So pressure ulcers. End-of-life patients with limited mobility and physical activity are at high risk of developing pressure ulcers. And this is a reflection of the compromised skin at end of life. And when pressure ulcers develop in these patients, they can develop in pear or butterfly shaped and are predominantly located around the coccyx and sacrum area. They can present in various different colours, from red, yellow, purple and black. But it's also worth remembering that if patients are developing moisture damage, they are at greater risk of pressure damage also developing. Pressure ulcers developing at end of life do have a sudden onset and normally appear when death is imminent, and this is normally within the last 7 days of life. The term Kennedy ulcer used to be used, but this was removed by NHS improvements in 2018 along with the national changes to the pressure ulcer categories. So it's worth remembering that any pressure ulcer that is found on a patient should be reported in line with your local guidance and investigated accordingly. Moisture-associated skin damage is an umbrella term, but includes incontinent-associated dermatitis, intertrigo, which is moisture-associated damage caused by sweat trapped between skin folds, as well as peri-wound and peristomal dermatitis. There are common sites of moisture-associated skin damage and where it can develop, but by no means is this list extensive, and moisture damage can develop anywhere. Particularly in palliative patients, it can develop around the neck, especially with patients who've got tracheostomies, under the axilla areas, under breasts, within the apron folds, between the fingers, the perineum, groin and genitalia, evidently from when the patient develops incontinence. Also the thigh area, you can develop moisture-associated skin damage, as well as the heels and between the toes. And then if we think again about the moisture damage, from moisture damage, we've got pressure damage. Again, the common sites aren't exhaustive and pressure damage can develop anywhere on the body. But common areas that pressure damage develops, particularly at end of life, back of the heads, the occipital area, especially common with patients who are wearing oxygen masks or CPAP machines, your elbows, the patient's hips, sacrum, buttocks, natal cleft, the malleolus on your ankles, as well as heels, and again between them toes. Obviously, these common sites are common that patients will develop this pressure damage at end of life, but as I've said, it is remembering that they can develop anywhere, and especially when devices are involved. So remembering your catheters and syringe drivers. So the umbrella of moisture associated skin damage. Again, it's all the different types of skin damage that can develop from moisture. So you've got incontinence associated skin damage. Again, this is where there's overexposure to the skin from either the urine or fecal matter. You have your peri-wound moisture associated dermatitis. This is from your wound exudate, most commonly your chronic wounds. And again, that's caused the skin to become overhydrated, and the enzymes against the skin are breaking it down, and that damage is developing and delaying that healing process, but also opening up the area for more bacteria. You've got your intratigo dermatitis. Again, as I've mentioned, this is caused from perspiration, so your sweat. And again, that can happen anywhere under apron folds and breasts, as well as the axilla areas. And you've also got your peristomal moisture associated dermatitis. And this is where the skin around the stoma formation has become damaged, again, due to that overhydration from that stomal fluid or mucus. But also remembering that saliva and mucus can contribute to moisture associated skin damage. And this is key with our palliative patients because they do commonly develop more respiratory secretions and more saliva. So that prolonged continuous exposure from moisture affects the way that the skin's pH is set. Now, the normal healthy skin likes the pH level to be between 4 and 6, and it's providing that good acidic environment and supports the surface of the skin and protects it from any bacteria. But in cases of overhydration, the pH of that skin increases, resulting in an alkaline environment that is really good for bacteria to grow and infection to form. And as you can see here, this image demonstrates that natural pH level for the skin and how we need to keep and maintain that balance from it being too acidic and too alkaline. So prolonged exposure to moisture to the skin does cause the skin to break down, and it loses that barrier and that protective function. So the overhydration of the skin, regardless of the underlying cause, disrupts that barrier and allows irritant to penetrate the epidermis. And once that skin is overhydrated, it is more prone to physical damage and also increases the risk of friction and shear damage developing. So Mr. Smith was a 60-year-old gentleman who had a diagnosis of carcinoma of the lung. He also, unfortunately, had COVID positive, and his preferred place of care and death was home. Now, Mr. Smith had a tracheotomy site, and this was formed whilst he was in the acute care, and he was discharged home for end-of-life care and had a syringe driver in place. When I first met Mr. Smith, he had extensive moisture damage to his neck, and this was from his copious respiratory secretions that were coming from his tracheostomy site. Unfortunately, Mr. Smith was not able to verbally communicate and relied upon squeezing of hands and his visual communication through his eyes. And when I did my first assessment with my colleague, we noted the damage and obviously cleansed the area because he'd got quite a lot of dried respiratory secretions to the site as well. And during this, you could see the amount of pain that Mr. Smith was in. And also on reviewing his authorisation chart for his medication, I'd noted that he'd been having the district nurses out for subcut medications due to pain. So obviously I assessed the skin and decided that the best form of treatment for Mr. Smith at this time was the Medicareplus skin protectant ointment. Obviously it acted as a real good barrier around the site for the respiratory secretions that he was producing, whilst also acting and healing and promoting the skin to resolve itself. Obviously, I was honoured to continue the care of Mr. Smith and was able to monitor the skin damage, and we were able to note an improvement with the product that we were using and enabled us to step down to the film. And we also noticed that Mr. Smith was requiring less subcut injections for pain relief. And when we were cleansing the site, when we were reviewing, his pain levels were less expression through his face, which was really positive and nice to see. Unfortunately, Mr. Smith is no longer with us, but I can say that we did notice an improvement. We didn't resolve the skin damage, but we did notice an improvement with the ointment and the film that we used for Mr. Smith. That then moves me on to Mr. Jones. So Mr. Jones was a 79-year-old gentleman who I met who had a carcinoma of the bowel. When I met Mr. Jones, he was having copious amounts of loose bowel movements due to his diagnosis and had presented to me with bleeding moisture-associated skin damage. Now, again, on my assessment, Mr. Jones had informed me that he was using more of his Oromorph, his oral pain relief, due to the pain levels that he was experiencing from his sacrum. And also he was unable to lie on his back due to the pain levels. This put Mr. Jones in quite a low mood. So obviously did all my assessment and initially went for the ointment. Again, due to the extent of the damage and the fact that the damage was bleeding. Due to this extent, I did go back and see Mr. Jones the next day and was promptly greeted. Now, I'm not saying that it is, but these are Mr. Jones's words, that thank you for the miracle cream. Now, genuinely, Mr. Jones hadn't needed any further analgesia, any oral opioid in the last 24 hours, and was able to sit on his bottom or lie on his bottom in the bed. So we continued with the miracle cream, as Mr. Jones liked to refer to it as, and within a week we stepped him down to the Medicareplus barrier film. And we, again, within 2 further weeks, were able to step him down to the cream. Now, Mr. Jones continues to use the barrier cream and has fully resolved his moisture-associated skin damage and uses the barrier cream as a prevention now. He doesn't want to go back to that stage again. He does still have his loose bowel movements due to his disease, but his skin is effectively managed now by using that barrier product. And Mr. Jones absolutely swears by his prevention. And then we've got Mrs. Peters. So Mrs. Peters is a 56-year-old lady who again has a carcinoma of the rectum, who also has liver and pulmonary metastases. When I first met Mrs. Peters, she had rapidly deteriorated and was only able to mobilise for short distances. She was having increased episodes of incontinence and general fatigue due to her immobility. And again, she was in low mood following the recent bereavement of her husband. On my assessment of Mrs. Peters, she didn't have any skin damage, but in light of the deterioration and in view of what was going on, we first as last used the barrier cream as a protection and prevention from any moisture damage from happening with Mrs. Peters. She's also started to use the lollipop, so the film around the stoma formation that she has, just to protect that skin so she doesn't have any moisture associated skin damage or any peristomal dermatitis due to that loose bowel movement or her episodes of incontinence. And that's the key part for Mrs. Peters, that we need to be protecting and preventing that skin damage from happening, because we know potentially she will be at risk. Which then moves me on to medical adhesive related skin injuries, so MARSI. And this is something that often isn't recognised and is often underreported. So this is defined as a skin damage which is related to the use of medical adhesive products or devices such as tapes, wound dressings, stoma products, electrodes, medication patches, and obviously wound closure strips. Now, these injuries can occur when the epidermal layers separate or if the epidermis completely detaches from the dermis. Now, MARSI is very much preventable, and it can cause unnecessary stress and pain for our patients. So it is our duty of care to ensure that the patient has a comfortable experience as possible, and we never should underestimate the discomfort of a dressing change or the removal of an adhesive. And any patient who comes into contact with medical adhesives can potentially experience MARSI. And these patients' skin are already vulnerable. Obviously, we need to be protecting the skin temperature, the colour of the skin, and that moisture level, but also remembering that the patient's elasticity gets weakened as we grow older, and the skin may be dehydrated, and obviously it gets frailer as well. And we need to observe the skin for any signs of irritation or damage that might be caused by that adhesive removal. So remembering that our palliative patients are at greater risk of MARSI from happening because them skin changes are happening very rapidly. And we need to remember that when we are changing them syringe driver sites, that again, we are at risk of the patients developing MARSI. Which promptly takes me on to Mrs. Wise. Mrs. Wise is a 70-year-old lady that I nursed who had end-stage heart failure. When I first met Mrs. Wise, she had gross pitting edema to her bilateral lower limbs and her lower torso, all from fluid retention due to her heart failure. Now, Mrs. Wise did require a syringe driver, but purely for symptom control. And in managing them symptoms, obviously, we were acknowledging that due to the edema and the fluid retention, the skin was at greater risk, not only of pressure damage due to the extent of the edema, but also medical stripping from the removal and reapplication of the syringe driver sites. So as a prevention, we used the Mediderm film in the lollipop version, and obviously this formed a protection layer between the skin and the medical adhesive, but also taken into consideration when we were removing the dressings that we were using the medical adhesive remover to aid that removal and prevent that skin stripping and protecting that dermis and epidermis layer. And I am pleased to report that Mrs. Wise is no longer on her syringe driver and developed no skin stripping and no skin damage during the time that she had the syringe driver in place, which was really key for Mrs. Wise. So maintaining skin integrity when our patients are nearing the end of life is based on regular skin inspection. And by doing that, we are able to provide optimal care and ensuring that patient comfort is pertinent, and we are preventing and managing the skin from any further complications. As patients progress through the end-of-life trajectory, it is key to ensure regular skin inspections and not only assess when deterioration occurs, but ensuring that prevention strategies are put in place and are still valid for the patient, and update them as the patient deteriorates and their disease progresses. The main function of barrier products is to protect and prevent the skin from damage, and that's not only from shear and friction, but also irritants. Modern barrier products are available in many forms, such as creams, films, and ointments, and they contain a silicone which acts as a real good water repellent, and they are designed to be applied thinly across the patient's skin. As we've discussed, the early identification of patients who are at risk of moisture-associated skin damage is key, and putting them prevention measures in place is part of the process, and it is not inevitable that the patient's skin will deteriorate. So remembering that prevention is better than cure. So ultimately, let's protect and prevent our patient's skin from breaking down. Obviously, the skin barrier products do provide a nice, transparent, waterproof barrier and are indicated for all degrees of moisture-associated skin damage, whether that be from mild through to severe. And it can also be used on our high-risk patients. And in addition, they can be an effective option for the prevention of that medical adhesive skin stripping. So remembering, MARSI is something that we can easily prevent from our patients and consider a barrier film. As you can see here on this slide, the Mediderma range acts as a step up and a step down approach. So you can go through any of the variant products dependent upon where that patient's skin damage is. And the prevention of skin damage is key, dependent upon the severity. So the patients may require the Mediderma S Total Barrier Cream, and this provides protection to intact skin or where there may be mild damage. And all you need to do is apply a small amount, and that will provide an adequate amount of protection to the patient's sacrum and prevent that moisture damage from happening. But remembering that the cream can be applied anywhere on the body. You also have the Mediderma S Total Barrier Film. This is an alcohol and preservative-free, non-sting film, and this is indicated for use between mild and moderate skin damage. It doesn't affect the absorbency of incontinence pads, which is really good for our incontinent patients, and it should be applied every 24 to 72 hours, or each dressing change or stoma pouch change. And again, this one's really good to be used to prevent that skin stripping. You also have the Mediderma Pro, which comes in a foam and spray. And obviously this is an ointment, and this is used to maintain the healthy pH balance of the skin. And it's a non-rinse moisturizing cleanser as well. This is suitable for the use of moderate to severe damage. And the two products, the foam and cleanser spray and the ointment, are used together. And obviously this is reapplied every 72 hours. If it is that the patient's skin does not improve, you do need to seek further specialist advice with regards to where to go for that patient's skin. So medical adhesive removers, these are really good and effective at breaking down the adhesive bonds, and this helps to minimize the potential of skin stripping. It also helps to reduce pain on removal and any discomfort when them dressings or devices are being taken off. They're used by gently lifting the edge of the dressing or device and then applying the product underneath, and that aids the removal and aids the prevention of that epidermis skin layer being stripped. And again, this is really key for using of our end-of-life patients, because it can reduce that discomfort and that pain element when we are changing any adhesive dressings or products. So to summarise, when managing skin changes at end of life, we should consider educating the patient and their carers on what the changes may be and what they need to look out for. We need to be completing regular skin assessments and ensuring that we are checking the skin holistically and checking all the bony prominences. We need to be implementing the most appropriate interventions that are specific to our patients to ensure their comfort as well as respecting their wishes. Unfortunately, skin deterioration is part of the dying process, but it's our role as healthcare professionals to support the palliative symptoms and provide that optimal end-of-life care. So remembering that we only have one chance to get it right for our palliative patients. So let's protect their skin as best as we can and prevent that skin damage from developing, because prevention is always better than cure. Thank you very much for your time. There are some free samples of the Lift Easy that can be found at the end of the broadcast on how to get those as well. Thank you.
Brilliant. Thank you so much, Stefanie. That was absolutely fascinating. Some really interesting case studies as well. So thank you so much for your presentation. That was brilliant. And I know we've had hundreds and hundreds of comments and lots of questions coming in. So we'll get cracking with those in a second. Remember, you can continue to submit your questions for Stefanie throughout the live Q&A. We'll get through as many as we can. If we can't get through to yours tonight, we will try and answer those in the next few days, and we'll post those onto our website along with the slides and the video link as well. Okay, so moving on to our first question, if you're ready, Stefanie.
Yep.
So question one is, as family and carer engagement is an important aspect of palliative and end-of-life care, how can you involve them with skin and wound care?
Obviously, quite some families like to provide personal care themselves for the relatives and for their loved ones. Obviously, some relatives do like to be actively involved in what's going on. So from my perspective, I would be educating the family to the best of their knowledge and what they want to know. But obviously, it's really key to involve the family in what's happening, because they're there with their loved one all the time. So they will know if their loved one is developing potentially some soreness, because they will be saying, oh, my bottom's a little bit sore, or they start fidgeting a little bit. But it's also key to be able to acknowledge and give them some awareness as to what to identify and what to look out for. So it's really good to compare it to scenarios that they might have dealt with in the past. So one example I use quite a lot with my relatives is, have they had children and have they looked after children? And 9 times out of 10 people have, and 9 times out of 10 people have changed babies' nappies. And we've all seen nappy rash, which again is the same formation of moisture associated skin damage. And as soon as you compare it to that, they're like, oh yes, I know what to look out for. So they know to be looking out for that redness of the skin and that damage developing. So for me, I think it's really key to gauge how the patient and their relatives are, and enable them and give them that information at the level that is required to them to be able to educate them, and they can identify and then ring the nurse if required.
Yeah, absolutely. Brilliant. Thank you very much for that. We'll move on to question 2. So question 2 is, when a patient is in the palliative stages, would you review the frequency of skincare intervention?
Definitely. Obviously, we all advocate if patients are at high risk of pressure damage developing, 2-hourly or even sometimes hourly positional changes to protect that skin integrity. During end of life and when that patient is in that terminal trajectory, it's cruel to be moving patients as frequent. So it's gauging a plan that is specific to that patient and is tailored to their needs and what is going on with them. It's also really key to involve them specialists that may be involved with that patient's care. So again, your tissue viability specialist team, your district nurses, making sure everybody is aware of what's going on, and also engaging with the family and the relative and the patient directly, because it might be that the patient can still vocalize that they don't want to be repositioned every 2 hours, and it's negotiating and speaking with the patient about it. But again, it's individualized to that patient and their needs.
Yeah, so I think actually question 3, you've answered quite a bit of question 3 in there as well, which is really handy. But so question 3 was, does turning the patient still apply to palliative patients, and how often? So you're obviously saying that it depends on the patient.
Definitely, it's still important to have that regular repositioning for the patient. The palliative patient is still at high risk of pressure damage developing. So by not positioning them, we are putting them at greater risk. But obviously it's identifying that and having the appropriate care plans in place, and also identifying and speaking with the family that if they don't want them to be repositioned, explaining what them risks are and what might happen to that patient's skin. And sometimes the patient's family will acknowledge them risks and not want that patient to be turned, or may say, okay, but can we just do it a little bit further? So we incorporate potentially the 30-degree tilt. So we're repositioning them, but not in an actual full positional change. We're just repositioning them slightly.
Okay, brilliant. And our next question's from Sharon, and this one links in to that same conversation. Are palliative patients at risk of pressure damage from hosiery?
They are, yes. Obviously, the patient isn't mobilising like they used to be. Again, they are immobile, so they are at greater risk of pressure damage developing. Particularly, I've seen pressure damage develop to the folds of the foot from hosiery and the inappropriate and ineffective application as well. So it's remembering that we need to be assessing that skin and removing that hosiery fully, and obviously reapplying it correctly for that patient.
Brilliant, thank you. So question 5 is from Rebecca, and Rebecca asks, should we be using dressings on moisture damage?
Again, it depends upon the damage. If there is a form of pressure damage within that moisture association, then yes, potentially there is a need for a wound dressing. If that patient solely has moisture damage, then no. I would be saying you wouldn't be needing a dressing, but again, it would depend upon your local guidance for where you work as well. So making sure that you are following your trust guidance, but for most moisture damage, you wouldn't be requiring that dressing, no.
Okay, brilliant. Question 6 is from Katie, and Katie asks, is it best practice to use barrier cream or spray as soon as a patient becomes incontinent in regards to end-of-life patients?
That's a good question. As far as I'm aware, there aren't any best practice statements that support that. But myself, as a professional, I do advocate that we using a barrier when a patient is incontinent, because obviously that skin is at higher risk of that pH change due to the acidic of the urine or the fecal matter. So for me, throughout my district nursing career, I have promoted that patients do use a barrier cream when they are incontinent, just to protect that skin damage from happening.
Yeah, brilliant. Thank you. Question 7 is from Sue, and Sue asks, how important is collaborative working with continence teams?
Very. For me, it is very important. It's making sure we've got the correct products on the formularies where we work. It's enabling that correct product at the right time. So for me, all specialists should be working closely together, but particularly continence and tissue viability and palliative care.
Yeah, absolutely, definitely. Question 8 is from Carol, and Carol asks, can edematous legs cause moisture damage on heels?
Yes, I remember nursing a lady many years ago who had bilateral edema and had bilateral weeping wounds. And excuse the way I'm going to describe it, because there is no other way of describing it. The whole of the sole of her foot or her feet were basically a mushy mess. And that was solely from maceration from the copious amount of exudate that she was sitting in. She was dependent edema. So she wasn't going to bed or anything. She was sitting in the chair all day, every day. And yes, she had extensive moisture damage to her feet. Unfortunately, before the lady passed away, we weren't able to resolve the damage, but by the use of barrier products, we were able to resolve it to some extent, and her ability to mobilize did improve. But obviously that could have been potentially prevented.
Okay, that's great, thank you. Question 9 is from Sue, and Sue asks, for patients with excessive perspiration and the effects on skin integrity, should barrier products form part of the initial assessment?
I would suggest yes, because again, it can form that barrier and prevent that excoriation. Obviously, it's not going to stop the excessive sweating, but it is going to prevent and protect that skin from the I can't say the word properly, but altering pH levels. So yes, I would be saying, but obviously consulting the GP as well to look at what else could be suitable for the patient for the treatment regime.
Okay, great, thank you. Question 10 is from Linda, and Linda asks, can barrier creams be used with oxygen? Yes,
they can. Obviously, with any products, I would be telling you to use them with caution. But from my knowledge with the company, and I have used them in the past, yes, the product that is on these slides from Medicareplus can be.
Okay, great, thank you. Question 11 from Anthea is, can you suggest any techniques for promoting quality of life in fungating wounds for those patients not quite at the end of life?
Again, fungating wounds, you can get moisture associated skin damage from obviously the continual leakage from fungating wounds. So using that barrier product initially. Again, consulting the formulary that you're working with, but looking at obviously protecting the skin looking at the form of dressing that you're using, but also considering anything charcoal, especially if you've got a malodorous fungating wound, because that will affect the patient holistically. Obviously malodorous, it will affect the way that the patient is eating and drinking, especially if you think on the upper torso, so breasts, or fungating on the face. It's going to affect the way that the patient smells and affects the way that they eat. So I'd definitely be looking at dressing choice and potentially considering charcoals and considering what's on the formulary where you are.
Great, thank you very much. Question 12, we've got quite a lot of questions obviously have come through tonight, so thank you everybody for submitting all of those questions. Keep them coming through. Question 12 is from Kiara, and her question is, does Marcy need to be reported with Datix?
That will be dependent upon your local policy within the trust. So I would advise to maybe have a chat with the tissue viability team to see if that is or isn't reportable within your trust.
Great, thank you. So I think we've got 2 more questions left. So question 13 is from Ella, and Ella asks, would you recommend 2 hourly repositioning?
Dependent upon the patient and what's going on with them, but routinely I would be advocating 4 hourly positional changes with my palliative patients who are in the terminal phase of life, so who literally are in the last days. I wouldn't be advocating 2 hourly positional changes, but again, you need to be making sure with your local guidance sort of thing. But for me personally, most of our patients are 4 hourly.
Okay, fantastic, thank you. And so on to our final question. Our final question is, how important is it to set realistic goals with respect to skincare in palliative and end-of-life care?
Very. If we don't set realistic goals, then we're not going to meet them. For me, obviously, it is preventing that patient's skin from breaking down. It is putting all of them prevention measures in place, but remembering that sometimes we can't prevent that patient's skin from deteriorating, whether that be due to moisture or pressure damage. The skin is an organ and the skin will break down, but it's just being mindful that we have got all of them preventative measures in place. But also for me, it's acknowledging that with the family as well, that just letting them know that skin damage can happen, but it's identifying that we have got all of them prevention measures in place for me.
Brilliant, thank you so much, and thank you so much for all your answers and insights through all those questions. I know there was lots of them, so I'm sure the audience is very, very happy with all your responses there. So this concludes our live training session. Thank you all so much for joining us tonight. We really do appreciate it. Thanks for all your comments and questions. We'll answer any that we haven't been able to answer with Stefanie tonight over the next couple of days. They'll be posted onto our website along with the slides and the video. Thank you, Stefanie. Again, thank you so much for all your knowledge and insights. It's been great hearing your presentation, and I'm sure everyone else appreciates it as well. Finally, thank you very much to Medicareplus for supporting this event. To get their free sample, the link should be on your screen, or it'll also be posted in the comments section and pinned by one of my colleagues. The Lifties sample page is medicareplus.co.uk/Lifties sample/. So the certificate link should also be on your screen now as well. That will also be pinned in the comment section, so you can't miss it. Remember to download the certificate to go in your CPD folder. You can access all the slides on the website and also watch back the video if you've missed anything or need to take some more notes as well. That'll all be available on our Facebook page and on our website as well. Don't forget to like our Facebook page, and that way you'll be able to see all of our future events. Our next event is on the 15th of April, and that one is wound exudate, getting the balance right. So we'll hopefully see you all for that one as well. Again, thank you, Stefanie. Thank you, everybody, for joining us tonight, and we'll see you next time. Thank you.